Hello, everyone. Welcome to the Neuroblastoma Parent Global Symposium. My name is Pat Tulungan, and I'm from the Children's Neuroblastoma Cancer Foundation, and I will be moderating this session along with Donna Ledwinski from Solving Kids Cancer US. The title of today's topic is The Role of High-Dose Chemotherapy in Neuroblastoma. It is being delivered today by Nick Bird, parent and patient advocate and chair of the trustees at Solving Kids Cancer UK, and Dr. Daniel Morgenstern, director of the New Agent and Innovative Therapy and Therapeutic MIBG programs at Sick Children's Hospital in Toronto. Before I do hand it over to our first speaker, I'd like to draw your attention to the panel on the right side of the screen, where you can submit your questions. There's the option to do so anonymously if you choose. Questions will be addressed after both presentations have concluded. Over to you, Nick, for your thoughts on this very difficult subject from a parent's perspective. Nick Bird.
Thanks very much, Pat. So I'm Nick Bird, patient advocate, and I'm here to talk about the role of high-dose chemotherapy in neuroblastoma. So just to say to begin with that I previously presented this at the SIOP 2021 virtual meeting in October. So I'm Nick Bird and I am Adam's dad. I'm a parent, patient advocate, and I am a current trustee of Solving Kids Cancer UK. This is Adam. He was diagnosed with high-risk neuroblastoma in 2009 at the age of 5. His disease was resistant to all forms of therapy, and he died 4 years later. This is Adam during autologous stem cell transplant in 2011. Transplant itself was relatively unremarkable for Adam, but signing consent forms knowing the potential consequences is a memory that's always stayed with me. The patient advocate perspective is not only formed through the lens of experience and observation, but it also incorporates knowledge and understanding of the research and treatment landscape. Both of the major cooperative groups, COG and SIOP, consider transplant to be standard of care. Tandem transplant in the case of COG, single transplant with busulfan melphalan within SIOP. By contrast, MSK has not used transplant since 2003 and now uses immunotherapy followed by a bivalent vaccine, as we've just heard from Dr. Shakil Modak. Today, there's a steady but modest stream of parents who deviate from COG protocol after induction, instead taking their children to MSK for immunotherapy and vaccine to avoid stem cell transplant. This is a selection of the scientific evidence that comprises the published evidence for and against transplant, as well as a number of articles reporting the adverse effects and long-term consequences. Again, to highlight that while there's great emotion and feelings around transplant in the parent community, we must always remain well informed by the evidence. So where are we currently with high-dose chemotherapy? Stem cell transplant has been used in neuroblastoma for over 40 years. While it's demonstrated improvements in near-term event-free survival, uncertainties persist. Acute complications have been greater with the emergence of transplant-associated thrombotic microangiopathy, TATMA, the full effects and implications of which are not yet known. Long-term survivor studies highlight the cumulative impacts of toxicities experienced by these young children in terms of severe adverse health effects. Although transplant is indicated for all high-risk patients by the cooperative groups, there is a well-annotated spectrum of different biological and clinical characteristics that identify subgroups for whom the relative benefit of transplant remains unknown. While results from MSK and SJD in Barcelona are intriguing, small single-institution retrospective studies provide insights rather than clear answers or practice-changing evidence. Regarding the argument that plays out over whether event-free or overall survival should be the gold standard, The endpoints that truly matter in such a young patient population are cured and with the fewest possible side effects, long-term side effects. In respect of this, there is a paucity of data on post-relapse survival and whether improvements in treatments such as chemoimmunotherapy have led to more children with recurrent neuroblastoma being cured. As I said, whilst my personal experience of transplant wasn't profound, I've been a part of the parent community for over a decade. In that time, I've seen transplant come up over and over again in the online parent forums. In preparing for the SIOP debate, I really wanted to represent the parent perspective as faithfully as possible. To that end, I asked in one of the online groups whether I could use parent experiences of transplant to pull out key themes. In doing so, I acknowledged there was a wide range of views, experiences, and attitudes. There was a need to represent themes rather than individual perspectives. The published evidence from MSK is limited, but there is a clear belief among parents that empirical evidence is strong and individual stories of families are actually compelling. This is an extremely complex subject, and taking sides will not move anything forward. The goal really is to move the discussion and debate forward on behalf of children and families by making our voices heard. The next slide, which I'll allow to speak for itself, presents a word cloud using comments gathered from the parent group, together with a few sample responses. And at this point, I should say thank you to all those parents who contributed to this part of the talk.
Thank you, Nick, for this very insightful presentation.
I haven't finished yet, Pat, sorry. So let's look at the main themes. Fear. Parents have to consent to this barbaric treatment, knowing the devastating consequences it has for some children. They're terrified about the stories that we read and hear about VOD and TMA, about immunotherapy being potentially delayed or unable to be completed because of complications. Among parents, there's an instinct not to subject one's child to the brutality of high-dose chemotherapy, in particular tandem, if scans are already clear. Difficulty understanding why you'd give a child who didn't respond to intensive induction chemotherapy even higher doses of chemotherapy as consolidation. High-dose chemotherapy with stem cell transplant is very much seen as the one-shot, all-in approach that will potentially limit salvage options in the event of disease recurrence. Conflicting information that parents receive about whether or not high-dose chemotherapy is necessary creates confusion and turmoil as parents wrestle with this impossible decision. And tragically for some parents, the decision to put their child through high-dose chemotherapy and stem cell transplant will result in lifelong profound regret. For parents, transplant is the most debated, confusing, contentious topic responsible for fear, trauma, and regret. For some parents, they're actually left traumatized and haunted by what their child endured, regardless of the outcome. However, we should say that not all experiences are bad. For some parents, putting their child through immunotherapy is actually the worst part of their treatment journey. The question of transplant in neuroblastoma should not be about pitting COG and SIOP against MSK and SJD. Framing the discussion in such a way is divisive and only serves to suppress meaningful engagement and dialogue. It's about what's doing best for children with neuroblastoma and nothing else. As a starting point, I'm sure we can all agree that the sooner transplant is not needed, the better. So my final slide ask the question, where do we go from here? Self-evidently, there is a role for high-dose chemotherapy in neuroblastoma until it's proven to no longer be needed. However, the speed of cooperative group randomized studies is a major issue, and we're out of the roadmap of going forward. We could still be giving children high-dose chemotherapy 20 years from now. We've already heard about chemoimmunotherapy, and I'm sure we'll hear about that more in the next session. But optimizing the use of chemoimmunotherapy is critical and may alter the treatment landscape substantially. Recent results from St. Jude provide a tantalizing insight as to what might be possible. There is a need for comprehensive data on treatment and survival, including post-relapse, to enable wise and well-informed decision-making. Ongoing controversy over transplant is divisive. It erodes trust, creates suspicion, and risks undermining relationships between parents and healthcare professionals. My call, therefore, is for brave leadership to be shown and for the cooperative groups to work together to develop a joint strategy and roadmap to re-evaluate transplant with the goal of de-intensifying therapy, at least for some patients. Development of the strategy should involve patient advocates as partners, and the outputs and vision be published to create shared understanding to build trust and confidence among the wider parent community. This is time for us all to engage as a sensible, productive dialogue and move forward together for the benefit of children affected by neuroblastoma. With that, I will thank you for your attention, and I will now hand back to Pat.
Thank you, Nick, for that very, very insightful presentation. Now I would like to turn this over to Dr. Daniel Morgenstern to present a summary of the background and challenges of this therapy, following from a debate held at the recent SIOP conference. Dr. Morgenstern.
Thanks very much. Hello again, everyone. So for those who don't know me from yesterday, I'm a doctor at the Hospital for Sick Children in Toronto, and I look after patients with neuroblastoma. I'm not currently part of the transplant team that actually looks after these patients. And I should also say, what I'm going to talk about is based on the discussions that were had at the SIOP meetings, and the conclusions from that really are sort of my own. And I'm not here sort of formally representing the views of either Children's Oncology Group or SIOP, but I really look forward to having a good discussion with you all about this. Briefly, my disclosures are the same as yesterday. So let's kind of get into the bit more of the background about this after that really important introduction from Nick about the challenges of this topic. So one of the problems in discussing this is actually we're not even terribly clear on the terminology we're using. I've just chucked on this slide all of the different terminologies that are used, from high-dose chemotherapy, transplant, myeloablative therapy, MAT, BMT, all of these different terms, which in the context of neuroblastoma really all mean the same thing. But actually what we're really talking about with high-dose chemotherapy comes down to something which is a bit simpler than that, which is that we're giving high-dose chemotherapy. That's the purpose of this, is to allow us to give stronger doses of chemotherapy, with the idea that that allows us to kill, to eradicate any neuroblastoma cells that are left. And it's almost as a secondary thing that because the chemotherapy is so high dose that it then will affect the bone marrow such that it can't recover, that we then have to give the stem cell rescue. And we're giving the patient's own stem cells back to them. So the important thing about this is really what it's about is the chemotherapy. It's not about a transplant. It's not about giving somebody else's stem cells. It's not about trying to put in a new immune system, which is the case in leukemia and patients when they have a BMT. And so for me, I think, to me, the best terminology is to use is high-dose chemotherapy, because that's really what it is. And then it's followed up by stem cell rescue. So where does this fit into our current therapy? And this slide is one that I showed yesterday when I was talking about the overall treatment strategy for high-risk neuroblastoma. And I'm not going to go through the details, you'll be pleased to know, but just to highlight that both of the two cooperative groups, SIOP and COG, start with induction chemotherapy, have surgical resection of the primary tumor at some point at the end or during that induction chemotherapy, and then go on to consolidate that response, so going to hold that response there with high-dose chemotherapy, and then finish up with radiotherapy and maintenance. So this high-dose chemotherapy component really comes in the middle of the overall treatment strategy. So let's just talk about what is the evidence for high-dose chemotherapy. As I mentioned yesterday, the reason we treat patients with high-risk neuroblastoma the way we do is that treatment strategy is built on evidence from previous studies, and each study has built on the evidence from previously to allow us to gradually improve the outcomes. And so these data are back from what's called the ENSG, which was actually the group before SIOP even existed. And the overall treatment strategy here was OPEC chemotherapy, so different from what we're using now, but induction chemotherapy, surgery, and then patients were randomized to either get high-dose melphalan, which is the mel in Bumal that we use now, or nothing further. So you can see the treatment overall was quite different from what we do now, but the graphs here, both in terms of event-free survival, which means the number of relapses, and overall survival, which is obviously whether the patient actually survived, show that the patients who got high-dose melphalan, that's the dark line, had a much better outcome than those who had no further treatment. So the conclusion from this was that, at least in the context of this study, high-dose melphalan clearly improved overall survival and reduced the risk of relapse for these patients. So that was sort of the first randomized evidence for the benefit of high-dose chemotherapy in high-risk neuroblastoma. This was a very important study from the CCG, the Children's Cancer Group, which was the forerunner of the Children's Oncology Group, and this 3891 study. And the overall treatment approach here was induction chemotherapy, surgery, radiotherapy, and then patients were randomized between either high-dose chemotherapy and what's called TBI, which stands for total body irradiation. So really very strong radiation, essentially to the entire body, and randomized against that kind of high-dose combination, which can also be called BMT, bone marrow transplant, against standard chemotherapy. And then to make this study a little bit more complicated, there was also a randomization between having cisretinoic acid or Accutane or not having Accutane. And the results of this study are also clear, but a little bit complicated. So on this side over here, I'm showing event-free survival, and event-free survival means risk of relapse. And you can see that the yellow line is significantly higher than the blue line, which means the risk of relapse was lower in patients who had the bone marrow transplant, had the high-dose chemotherapy, than those who had continued chemotherapy. What's complicated is when we look at overall survival, you can see that early on the lines are very close together, and actually they kind of cross over. And so when we get out here, it looks as though the bone marrow transplant arm is better than the continued chemotherapy arm, but actually the statistics don't show that difference because the lines cross. And so it's unclear from this study, at least, whether the high-dose chemotherapy really improves overall survival, long-term outcomes, even though it clearly does improve event-free survival, reduces the risk of relapse. Another line of evidence comes from the German study, and the German cooperative group is called the GPOH, and this was their NB97 study. Again, a very similar overall structure: chemotherapy, surgery, radiotherapy, and then high-dose chemotherapy with CEM, which is a different combination of chemotherapy drugs, or standard chemotherapy. And then some of these patients received anti-GD2, some of them received cisretinoic acid on its own. And if we look at the graphs again, the green line is the ones who had the, again, different label here, ASCT, autologous stem cell transplant, the high-dose chemotherapy, and the black line is those who had maintenance chemotherapy. And you can see both in terms of event-free survival and overall survival, there was an improved outcome, a benefit for those patients who had the high-dose chemotherapy. And then most recently, as many of you are probably aware, the Children's Oncology Group did a randomized study saying, well, if one high-dose chemotherapy is good, what about giving two, one after the other, tandem high-dose chemotherapy? And in this study, patients received induction chemotherapy, surgery, and were then randomized between either one high-dose chemotherapy with SEM or a tandem, so one high-dose, recover, and then do it again with a different chemo, and then radiotherapy. And many of these patients received antibody. For simplicity, I'm just showing the curves for the patients who received immunotherapy after the end of their consolidation, after the end of their high-dose chemotherapy. And you can see here that there's a clear benefit in terms of the tandem over the single in terms of event-free survival. And it looks, at least in this subgroup, a benefit in terms of overall survival as well. But it's important to recognize that in the overall study population, although there was a benefit in reducing the relapse rate, there wasn't a clear benefit in terms of the overall survival. So just in terms of the practicalities, one of the things that's a little bit complicated about high-dose chemotherapy is the criteria for giving the high-dose chemotherapy are different in the protocols run by the Children's Oncology Group versus SIOP. So SIOP has always taken a much kind of stricter view in terms of who is eligible for high-dose chemotherapy on study, and have said you've got to have had a good response to your induction chemotherapy. And good means at least a partial response. So that means at least a halving of the number of your MIBG spots. Plus you've got to have cleared your bone marrow disease. Plus you're not allowed to have more than 3 MIBG spots. And for those patients who don't meet those criteria, then they're not able to go on to high-dose chemotherapy on study. In the Children's Oncology Group, a slightly different approach is taken, which is to say, as long as you've not got progressive disease, so you've got stable disease at least, then you can carry on to high-dose chemotherapy. But in fact, the situation is complicated because many clinicians would say, well, actually, I'm not happy with only stable disease, and I'm going to give some more treatment to try and get a better response before going on to high-dose chemotherapy. So even though the rules of the studies may say one thing, actually, in terms of how we manage patients, we don't always follow exactly what it says in the protocol. Obviously, if we don't follow the protocol, then the patient has to come off protocol. That's important to say. So I've presented a whole bunch of evidence for why high-dose chemotherapy is of benefit for patients with high-risk neuroblastoma. So, that really highlights the question, so what is the problem? Why are we having this debate? And I think, as Nick has highlighted, there are kind of 2 critical reasons for this. So one is that high-dose chemotherapy is clearly not a straightforward form of treatment. It comes with a significant risk of side effects, of liver toxicity, of infection, of damage to lungs, of hearing impairment, of damage to kidneys, of long-term effects on fertility. And so this is not something that we undertake lightly because we know that the side effects can be really significant. And of course, the other challenge that we have as a global community where we do know what everybody else is up to is that Memorial Sloan Kettering and then more recently SJD in Barcelona have routinely now dropped high-dose chemotherapy from their treatments for high-risk neuroblastoma. And so that raises a question for the rest of us of, well, are we still doing the right thing if they're not doing this anymore? Are they doing the right thing if they're not following what we're doing? Why is there that difference? And so I just want to kind of talk a little bit about why there is this difference of approach. And so these are the published data from the Memorial Sloan Kettering Cancer Center approach. And what these figures show essentially is on the left-hand side, progression-free survival, which is very similar to event-free survival, basically the risk of relapse. And on this side, the overall survival, which is overall survival, where the patients survive or don't. And each of these lines is a different era of their treatment. So over time, they've gradually improved their treatments. And so in the current era, where they're using intensive induction chemotherapy, surgery, radiotherapy, and then 3F8-based immunotherapy. So again, anti-GD2, but a slightly different antibody, plus or minus the vaccine. Then they're not now using high-dose chemotherapy as part of their routine strategy for high-risk neuroblastoma. And one way to look at these data, which importantly say this is not a randomized study, these curves are different curves over time, but broadly the numbers look pretty encouraging and are probably approximately equivalent to those from COG and SIOP. And then this is a retrospective look that they did comparing the outcomes, this is overall survival, between the patients that they treated at Memorial Sloan Kettering who had already had a stem cell transplant somewhere else versus those that were treated there and did not have a stem cell transplant. And at least in terms of this analysis, for patients who received the 3F8 immunotherapy at Sloan, there was no difference in survival between those patients who'd had stem cell transplant and those who hadn't. So to get to the kind of meat of this discussion, how can we begin to reconcile these 2 things? The data that suggests that high-dose chemotherapy is beneficial versus the data from MSK and Barcelona suggesting that actually their outcomes are as good as anybody else's when they're not using high-dose chemotherapy. And I think the important answers are the ones that I put on here. So the data from MSK and the data from Barcelona are single institution studies. And we know that if you publish data from one institution, it generally is better than the overall outcome for a much larger group of patients treated across multiple institutions. And the reasons for that are complicated, but they're to do with selection bias, that maybe only certain patients are well enough to make it to that single hospital. We know that expertise being centered in one place can alter outcomes compared to patients being treated in multiple, maybe smaller centers. Crucially, the treatment that MSK is not the same as the treatment everywhere else in terms of the details of the induction chemotherapy, the details of the antibody. And also, of course, the data that MSK are showing are really for those patients that followed through on their protocol and had a good enough response for them to feel happy with carrying on with the immunotherapy. And so there's this question mark, well, what about the entire population? And we know, as I said yesterday, that if you look at the outcomes for everybody from the point of diagnosis, those are different from the outcomes from a point further down treatment, such as starting immunotherapy, because the patients with the most aggressive disease who are not doing well have come off your study early on. So let's just talk about this further, how we can reconcile this and think about what are the criticisms that could be put against the randomized data that I showed you at the beginning. And so, excuse me, one of the points that's raised is, that's great, we've got these randomized studies of high-dose chemotherapy against no-dye high-dose chemotherapy, but they were performed with old chemotherapy. And the first study I showed you with, was a long time ago with very different chemotherapy, and before we had immunotherapy. And so one of the big questions is, well, are these studies still relevant in this era now when we've got immunotherapy in different components of treatment? And I think that is a very valid point. And I think we can't escape the fact that the pure randomized studies between high dose and no high dose were done a long time ago. But I think on the other hand, the tandem study that I showed you last was done in the era of modern therapy. And those patients got the induction chemo that we're using now, and they had immunotherapy, many of them. And that study showed a benefit of tandem over single. And so it didn't technically show a benefit of single or tandem over nothing. But in my mind, it's hard to imagine that if 2 high-dose chemotherapy is better than 1, that doesn't also imply that 1 or some is better than none. So it's not direct evidence, but I think it strongly implies that. Another criticism is that the studies that I've shown show that clearly high-dose chemotherapy improves event-free survival, which means it reduces the risk of relapse. And I think hearing the speakers at the SIOP meeting, I think everyone accepts that that is what the randomized data show. The controversy comes over the question of, does high-dose chemotherapy improve the long-term overall survival? Does it actually change the long-term outcome? And the challenge here is, ultimately, I think we just don't know for certain, because when you do a research study, you have to decide up front, what are the questions that you're going to try and answer? And yes, you can look for other answers, but often your study is not designed to answer those specific questions. And the reality is that the studies that we've done recently were powered, which means they were designed to look for benefits in event-free survival, which means reducing the risk of relapse. They were not designed to show changes in overall survival. And part of the reason of this is because, of course, overall survival is impacted by what other treatments a patient might have if they relapse and what happens next. And that can make the analysis of the study complicated. So I don't think it's fair to say that the studies prove that there is no effect on overall survival. They just don't provide us with enough information to know for certain. And so I think the argument is, well, if they reduce the risk of relapse, surely that is likely to improve the overall survival. And that is fair, surely it's likely, but arguably it's not definitive proof. And so there is some scope for debate there. And finally, this important question of, well, maybe not everyone benefits from high-dose chemotherapy. Maybe not all high-risk patients need high-dose chemotherapy. Maybe it's only some of them who need that. And I think this is also a very valid question, but the practical question is, well, what would we do with that? How would we actually select which patients don't need high-dose chemotherapy? And that is a question we just don't have the answer to at the moment. And I think the important data that came out of the tandem study is that obviously the patients who had a better response to induction chemotherapy did better in the long run. But actually, each group of patients, those with a good response, those with a less good response to induction chemo, each group did better if they got a tandem transplant than if they got a single. So for those patients who didn't have a great response to induction and whose outcome overall is less good than if they had had a good response, even in amongst those group, the patients who got a tandem still did better than those who got a single. And so that makes it very challenging to say, well, who would we think about dropping this for? And so, as I said, I can't speak officially on behalf of COG and SIOP, but I just wanted to ask and try and at least begin to answer this question. Well, why isn't COG or SIOP doing a study without high-dose chemotherapy? And I think, the real answer is that this is a topic that is definitely being discussed within those collaborative groups, because none of us want to be giving high-dose chemotherapy. None of us have a kind of vested interest in doing it. Ultimately, what we want to do is to ensure that the outcomes for patients are as good as we can get them to be. And I think the challenge at the moment is that it's very difficult to come up with a study to reduce treatment for patients with high-risk neuroblastoma, because at the moment, our overall outcomes are not good enough. We're not at the stage of saying, well, we can cure 95% of patients. Let's think about reducing treatment and reducing toxicity. We're at a point where, unfortunately, there's still a significant number of patients who do not have a good enough outcome and whose disease comes back, for whom we've got to continue to try and do better. And it just feels very difficult at the moment to try and reduce treatment by taking away high-dose chemotherapy. And the further complexity that I've already kind of alluded to is, well, if we were to design a study, which I think will come in the future, where we're going to drop high-dose chemotherapy, who are we going to drop it for? Are we going to take the patients who have an excellent response to induction chemotherapy and who probably have the best outcome overall and say, maybe you don't need high-dose chemotherapy? Well, we could, but the problem with that is that maybe their great outcome is because of the high-dose chemotherapy. And if we take it away, maybe they'll do less well. Or do we go to the other end of the spectrum and say, well, what about the patients who don't have a very good response at all to induction chemotherapy? Is there any benefit in giving them high-dose chemotherapy at all? Does it really add anything? And there the challenge is, well, if these are patients who don't have a very good outcome at the moment with our current treatment, do we really want to take away an element of treatment if we've got nothing better to replace it with? And so I think in practice, where we're going to have to go with this is to wait to see if we can get to the point of really finding a group that we've improved outcomes substantially with our current treatment or with new treatments, for instance, combining immunotherapy upfront with chemotherapy. And maybe at that point, we can begin to think about a randomization to take out high-dose chemotherapy. But it's really very challenging, because the big cooperative groups in their trials have a real responsibility not to do a study that leads to a worse outcome for patients, because that would really be a tragedy to have a study where the outcome was less good than it had been before. So in terms of take-home messages, I think there is general agreement from COG people, from SIOP people, and actually from those from Barcelona and Memorial Sloan, that there is evidence that shows that high-dose chemotherapy improves event-free survival. Where there is specific debate is about, does it improve overall survival in the long term? I think the data from Sloan and Barcelona are intriguing and raise important questions, but it's very difficult to generalize from non-randomized data from a single institution to say on the basis of that, we're going to suddenly directly change treatment in the big cooperative groups. And finally, late effects are clearly really important. And as we learn more and more about the late effects of treatment, in some ways it gets more and more problematic as we have a bigger understanding of what we're really doing to these children in the long term. We have to find a way of tackling that. But on the other hand, we really have an obligation, I think, not to compromise the chance of cure, because cure has to come above all else. We have to take into account late effects, but I don't think we can do that at the risk of compromising cure. So that's the end of my sort of presentation, just to kind of set the scene. I'm going to hand back now to Pat or Donna to chair a discussion, I hope. Thanks.
Thank you, Dr. Morgenstern. Just a lot of food for thought, a lot of questions, that I think parents will have. I'm going to turn this over now to Donna Ludwinski, and she will share the questions that we've received from the audience for our speakers. Donna?
All right. Thanks, Pat. Yes, I agree with you. A lot of food for thought. Well, we have some excellent questions that came in, and one that I'd like to start with on the heels of what you were talking about, Daniel, to do with the evidence that those who had immunotherapy seemed to benefit more from Tandem than those who did not have immunotherapy. Is there any rationale or explanation? Because that counters this idea that the era of immunotherapy maybe, we can abandon some of these toxic approaches.
Yeah, I mean, I think one of the challenges is that we still don't really understand how to predict who benefits from immunotherapy. And I think we also don't really fully understand the mechanism of high-dose chemotherapy. So one thing that's possible is that obviously, as part of the process of having high-dose chemotherapy, you use the chemotherapy to try and kill any remaining cancer cells. But incidentally, it also knocks out most of the bone marrow, which then means when you give the stem cells back, the bone marrow recovers, kind of gets rebooted. And it's possible that a kind of secondary effect of the high-dose chemotherapy is to reboot your immune system in some way such that the immunotherapy then has a different effect than if your immune system had not been rebooted. And we don't really understand enough about that at all at the moment. But it is possible, therefore, that there is actually a direct interaction between giving the immunotherapy in a patient who's recovering from the high-dose chemotherapy versus giving the immunotherapy in a different setting. But we just don't know enough about the details of that at the moment.
Okay, thank you. Thank you. We have a couple of questions regarding the impact of transplant on MIC-N specifically. Can you talk to that particular group? Is there any indication that it's more important in MIC-N amplified than non-amplified?
Yeah, so it's very complicated, this. So there's a small group of patients in whom MIC-N status is critical because it takes them from being non-high risk to becoming high risk. So those are patients who are babies with metastatic disease or patients with localized tumors. And clearly in those patients, the MIC-N makes a dramatic difference because if it wasn't for the MIC-N, they wouldn't need high risk treatment at all. And then there's patients who are, as it were, our main group of high-risk patients, who are those who are not infants who have metastatic disease. And in that group, the role of MIC-N is actually very complicated. And it may be that actually patients with MIC-N amplification have a better long-term outcome than a worse long-term outcome in that specific group of patients with high-risk metastatic disease. So it's not as simple. So specifically in terms of the transplant, actually the data shows, I was actually just looking it up because I got a key on the question, so that was very handy. So the data from the publication on the Tandem study says that when they did the analysis of looking at all of the different risk factors in terms of outcome, actually MIC-N status did not make a difference in outcome, whereas the Tandem versus a single did make a difference. So that suggests that the Tandem is beneficial regardless of MIC-N status, and MIC-N status doesn't really make that much of a difference if you are already in that high risk population.
Very good. Thank you. Now, there are also a couple of questions to do with Tandem. If there's an unfortunate circumstances with the first transplant, what are the strategies putting the child through the second one? What happens if they can't do the second one? Do you have any information on that group? And I'd be curious to know how common that is.
Yeah, that's a good question. I don't know that those numbers are immediately available. I'll look them up if I get a chance in a minute. But it is a worry because the way that the Tandem transplant works is that the first part of it is with cyclophosphamide thiatepa, and the second part is the SEM, a slightly adjusted dose of the SEM, which is carboplatin etoposide melphalan, slightly adjusted than if we were giving SEM on its own. And I think most of us would feel uncomfortable about a patient who had the high-dose chemo with the cyclothio and was unable to get the SEM because of toxicity. And I think we would probably feel in our hearts that we had done them a disservice because of that. And so I think it's very important to reflect carefully before embarking on a Tandem high-dose chemotherapy to think, is this patient suitable for this? Is the organ toxicity, is the history of infections, is their overall status good enough for me to have a good expectation that they're going to be able to cope with both of these? And in our practice, in those circumstances where we think that there's a particular worry about a patient getting through Tandem, we might actually elect to do a single on the basis that we feel that, as it were, a good solid single is better than half of a tandem, if that makes sense. But it's a very good question, actually, whether there are data on that at the moment. I will look that up and see if I find a way of answering between now and the end of the session. Depending on how many questions we can direct to Nick.
Right.
Not too many.
Well, I have a really good one for Nick that's coming
thanks.
up. Yes. So one of the things that you mentioned about the struggle about reducing therapies, for high-risk neuroblastoma is understandable. But I'm curious about when that has happened in the past. For example, you mentioned total body irradiation was used in the 90s, and of course that's not used anymore. And there was a pilot with Tandem that was done, I think, in the early 2000s that included total body irradiation. So what's the rationale for taking away total body irradiation if those outcomes still weren't good enough? Or reducing, localized radiotherapy doses, or, there have been changes like that, not a lot, but how are those decisions made, which seem to be reducing, treatment?
Yeah, it's a tricky. I honestly don't know the history of the discussions that were had at the point when TBI was dropped. I think probably the feeling was that there were enough advances in other components of treatment that it was no longer felt to be necessary or beneficial. But I'll be frank and say I don't actually know the details of the discussion that were had. I mean, I think the radiotherapy is a slightly different question because it's one where we've got more access to data because we've got information about the risk of local recurrence as compared to metastatic recurrence. And I think most of us would feel that the radiotherapy, which is really given to the site of the primary tumor, is mainly about achieving good local control. It's not necessarily about preventing metastatic relapse. And so it's kind of a less fundamental thing to change, I guess.
There's an interesting question about the term chemosensitive and the fact that, the induction has certain chemotherapies and then the consolidation has different chemotherapies. So the question is it possible that you have a good response to something like rabbit Kojak, but that you wouldn't respond to the chemotherapies that are contained, like, for example, Bumel? So really the bottom question is chemosensitive, does that term apply to all chemotherapies?
It's a great question. I mean, I think in my mind, I think it's overly simplistic to call something chemosensitive or not chemosensitive, because if that was truly the case, we would treat every cancer with one single chemotherapy drug and they would all respond if they were chemosensitive. And clearly we know that chemo is not chemo. That's why we use multiple different drugs, because we know that different drugs are effective in different tumor types. And so in my mind, a tumor that doesn't respond well to induction chemotherapy is not one where I would necessarily say, okay, there's no point in giving any more chemotherapy. To me, the answer was no point in giving the same chemotherapy. I need to find something different to treat that with. I think the challenge is we don't actually have a way, again, on a patient-by-patient basis to predict, is this tumor going to respond to this drug? Is it going to respond to that drug? Is it going to respond to this combination of drugs? And so what we're stuck with is looking at data on a population level and looking at the average. And so on average, patients who have rapid Kojak, whose tumor responds well enough for them to, on average, get Bumel, overall do better when they get the Bumel than if they didn't, and actually do better than if they got carboplatin etoposide melphalan. And I think an argument to demonstrate that the actual chemotherapy really matters are those data from the European study, which compared Bumel against SEM and showed that Bumel was better than SEM, but also actually that the outcomes of the patients who got the SEM were probably less good than expected. And probably that is because in North America, we don't give any carboplatin, which is the CBID of the SEM. We don't give any of that carboplatin in induction. And so if patients get SEM at the high dose, that's the first time the tumor has seen that drug. Whereas in the European protocol, rapid Kojec, the C in Kojec, is carboplatin. And that means the tumors have already seen carboplatin, and then we're giving carboplatin again. And so to me, that's one possibility for why there was that benefit. Nick?
So I've got a question for you, Daniel, on that.
Well,
It's about, well, I'm afraid it is. So in HR2,
yeah.
so I totally agree your point about it depends what chemotherapy you've seen. In HR2, obviously there's a tandem randomization, which is high-dose Thiotepa followed by Bumel.
Yeah.
But there's also an induction randomization, which is GPOH versus Kojec. But all the evidence from GPOH, which is actually probably the longer term evidence that exists for high-dose chemotherapy, is actually GPOH followed by MEC, which are the same drugs as SEM.
Yeah.
But in HR2, GPOH followed by MEC doesn't exist.
Yeah. So again, I mean, I wasn't involved in the discussions to decide what is included in the study. I mean, I think it reflects the reality of clinical trial design, which is that ultimately it's impossible to ask every question that you might want to ask. And I think a pragmatic decision was probably made that said Cypen had already established that at least after Cypen induction rapid Kojec, Bumel was superior to SEM, and that the next question people wanted to ask was tandem Bumel better than single Bumel? And I think then the question about MEC, so the other way around of SEM, was deemed a kind of secondary question and was not taken forward. I mean, you're right that theoretically either Bumel or Bumel in tandem could be less good than SEM after GPOH induction. But I think it's the reality of clinical trials, which is that it's impossible to answer every possible question.
So I guess my point would be that given that the one thing that this discussion and indeed the discussion at SIOP demonstrates is how complicated this is with all these combinations, really that leads, and obviously the one thing that has been shown promise is obviously the innovation with chemoimmunotherapy is actually start to, I'm not suggesting that tomorrow there should be a randomized study to reduce high-dose chemotherapy or not high-dose chemotherapy. It's more about trying to plan out a roadmap of how we attempt to start to reevaluate the use of high-dose chemotherapy in the future, rather than just planning out this high-risk trial, executing it, waiting for the results, and then see what questions we can ask in the next one. It's actually more about trying to plan out a forward path. Obviously, there has to be some flexibility in it because nobody knows the results of any trial until it's completed. But at the moment, we have all these different combinations. There are lots of uncertainties. We don't know precisely what the situation is. And we also don't know for the various different subgroups and clinical characteristics, whether it's MICN or in response to induction or different subsets of patients, like you said, MICN amplified with non-metastatic disease, whether or not high-dose chemotherapy is beneficial to those patients. But what we do know about intensification is that we're giving 100% of the patients more treatment. So we're giving all those patients who would already have not relapsed, we're giving them additional toxicity. And obviously the problem with that is that we all know about the acute side effects, and they are all published in the papers, but the longer term consequences aren't actually part of the study results themselves. And I think that's shown in the tandem transplant with TMA, which isn't actually an adverse consequence of that study itself.
Sure. I mean, I think the long-term data can't be part of the primary publication because otherwise we'd never know the results. But I think the community is recognizing the importance of collecting those long-term data, and that's why there's been the Learn study and others to collect it. I mean, I really agree with your point that I think the easiest way to begin to chip away at this is going to be to move away from having high-risk neuroblastoma towards substratification within that high-risk neuroblastoma. And we've already begun to get there, because in COG, patients with localized, non-MECAN amplified, unfavorable histology neuroblastoma are considered to have high-risk neuroblastoma, but they are not eligible for the current high-risk study. So they're not getting the escalation of treatment that is what we're testing at the moment. So already we're beginning to kind of pick out the ones who we don't think need the further escalation. I mean, I hear you in terms of saying we need a strategy for how to take this forward. I guess the challenge is, and maybe this is where the parent community needs and the advocate community needs to kind of tell the organizations, is in a world where we can only ask a limited number of questions, do we want to put a pause on trying to improve overall outcome in order to try and tackle toxicity? Or do we continue to think that actually improving overall outcome has to be the most important thing, if we accept, which you may or may not accept, that we can't do both at the same time because of practicalities of trials?
One question, or one thing that I've thought of talking to a couple of the survivors is, the high-dose chemotherapy is, again, obviously very toxic and everything, but what about things like, the radiation? Maybe women with, having radiation to the chest area, and possibly getting breast cancer later, are those kinds of things also being thought about, as well as reducing, high-dose chemotherapy?
Yes, I mean, I think as a community, we're becoming ever more aware of the terrible long-term consequences of what we do. And actually, at the last Children's Oncology Group committee meeting, we had a whole session on late effects and how we could begin to think about improving how we manage that in the context of the treatment studies. And certainly, the challenge is that everything we do has short and long-term effects. Surgery potentially has long-term effects. The induction chemo is not benign. The immunotherapy, has definite short-term effects. We think at the moment it doesn't have a lot of long-term effects in most patients, but we've got to be careful. And so I think it's a real challenge, and I think we're not ignoring it as a community, as a professional community, but I think we are kind of a bit stuck as to how to tackle it because of this difficulty that overall the outcomes are still not good enough. And I guess, Nick, you're right. If at the point of diagnosis we could take a patient with high-risk neuroblastoma, run some sort of test on them and say, you are a patient who is going to have a great outcome if we don't do X, Y, Z, that would be perfect. That's what we really need. But we're not there at the moment. And in many ways, the challenge we've got is that it's almost very difficult to even get those data, because, of course, the only outcomes we can look at are for patients who've been treated in the way that we've treated them already. We can't look at what their outcome would have been if we treated them in a different way. So it's really challenging in practice.
Yeah, for sure.
There's so many good questions, and I'm afraid we're not going to have enough time to get through them all. But I do, several kind of hit on the theme about those subsets. So age, the breakdown for age, do young children benefit better than older children? Also, like stage 3 versus stage 4. And this is kind of related to what you just said, looking at the outcomes of those who complete the therapy versus those who go off the trial. We don't really have good data on those outcomes, right? So if only half, like with the tandem versus single transplant, only about half were randomized, isn't that right? So what happened to the others? What happened to the other half? What do those survivals look like? And what treatment did they get?
Yeah, no, I think these are great questions, and I'll be honest again and say I don't have the answers at my fingertips. And I think this is a challenge in terms of how data are put out into the community, which is that the data that come out first are the data that reflect the main question that was answered in the study. So the paper has been published, which says what was the outcome of the tandem versus single for the patients who were randomized to tandem versus single, because that was the thrust of what the study was about. And then I think over time, all of these other data will come out, because it will be possible to look for the outcomes of those patients who were not randomized on the study. But I kind of share people's frustrations that those data are not readily available at the moment. And that, unfortunately, is just because it takes time, money, effort to generate those data. And it's much easier to prioritize the data that are needed for a particular scientific question than the whole totality of the data that those of us in the community might be interested in. I mean, I think it's important to say that as future studies are developed, we always would go back to the data to say, well, hang on, we need to know specifically about this question in order to inform our decisions about this study. But I agree, we don't have everything in the public domain, unfortunately.
Makes sense. Well, back to you, Nick, about this idea of advancing the conversation. What can advocates do to be, further stimulating the question? What role can advocates play in this, do you think?
Thanks, Donna. So I think for me anyway, the opportunity to speak at the SIOP debate on stem cell transplantation, and then this session here, which Pat put together, I think that this is the start of trying to have a reasoned conversation. And there are lots of stakeholders. Obviously, there are, as Daniel said, improving cure rates is everybody's primary objective. But there are many survivors who suffer very profound consequences from treatment, including early mortality. And I think over the years, this has come up a lot in parent forums. We see, several posts a week of parents wrestling with the decision about, should I do tandem transplant because my child's already in remission, and if there's no evidence of disease, why would I want to put them through megadose chemotherapy? They've had second opinions potentially, and there's an alternative route which avoids transplant. And it's traumatizing for parents. And I think one of the other things that's happened is that the conversation almost has become so polarized between the cooperative groups and individual institutions that it has prevented a kind of grown-up, mature conversation and debate, because people have been too frightened to talk about it. And I think that's unhealthy. And I think just putting it back on the table and talking about it, the uncertainties, the unknowns, etc., without it being in some way threatening to anybody, I think is actually the way that we're going to take this forward in the most productive way.
Yeah, I agree with you, Nick, that I think it's important to have these discussions, and I would, reassure people on the call that these issues are not being ignored by the cooperative groups. They are very much being discussed, and I think both cooperative groups would love to see the day when high-dose chemotherapy was not necessary. We'd love to see the day when we had a treatment for high-risk neuroblastoma which was non-toxic. So it's not that I think anyone is wedded to it. I think the real challenge is that whatever discussion is had, I think ultimately the evidence is just not available at the moment to say what is the right answer. And so in a way, this is not something that can be settled by a discussion and then everyone coming to agreement, other than that we still won't actually know the answer, even if we find a way forward. And I think the cooperative groups are thinking about what that way forward is.
But I mean, obviously to that, the way to find the answer is to conduct the studies. And then the question is, at what point can you conduct the studies, and which studies do you conduct?
Yeah.
It's somewhat of a chicken and egg question, isn't it? To say you don't have the evidence, the only way you're going to get the evidence is to undertake the studies to
Well, the simplest study
find the
design
evidence
would be to say, let's take the current Children's Oncology Group standard or the current SIOP standard and randomize patients between that and treatment at MSK or MSK's treatment schedule, for instance. But the challenges of that are pretty dramatic, because there are many aspects of the treatment at MSK which are different in terms of, for instance, the antibody therapy. And also, I still think there is a big danger in that of doing a disservice to a group of patients and then potentially having a worse outcome than expected because of not having had a key component of treatment. Because once you start randomizing the MSK approach, you're talking about using that approach in a multi-institutional setting, not in a single institution setting. And we know that that will change the data. So, I mean, you know, I think it's...
And I don't disagree with that at all. And
so I guess in a way it comes down to a question of, no, this is not our decision, but would it be worth it? Would it be worth the risk of a study which actually had a worse outcome for a group of patients than, as it were, standard? Would that be worth the risk to get to a point where it actually maybe gave the opposite answer, which was the answer we want, which is that we don't need the high-dose chemotherapy, we can do the different approach.
Right. And that's so complicated, what you referred to earlier about the post-relapse therapies and why, you know, overall survival might not be, you know, as bad in that group. Just because they suffer an early relapse or a relapse doesn't mean that, you know, it's completely done. There are no options.
So can I just say, I mean, this is one of the issues. So I think one of the issues is that there is incomplete data around population data, around patients and the treatments they receive and their survival, including long-term survival post-relapse. So there's anecdotes and there's empirical evidence, but there isn't good data, and it's only with good data that you can actually make good decisions. And then the other thing, in particular with the MB 2012 study from St. Jude that Dr. Wayne Furman presented at ANR, that if the promise of chemoimmunotherapy being used in frontline improves outcomes, then we may be in that position of what is the role for high-dose chemotherapy in the next iteration, if you like. There's lots of ifs in that, but again, it's about trying to plan out what might be the roadmap.
Yeah.
For the future.
I mean, simplistically, Nick, I think, and again, this is not official policy, but my prediction. I mean, my prediction is that the next round of studies are going to be asking chemoimmunotherapy and induction questions, and the round after that will be the ones that could ask a high-dose chemotherapy question potentially. But that, unfortunately, for everyone is 7 or 8 years away, and that may be deemed unacceptable.
Yeah.
Okay. All right. I think that's all the time we have for the questions that have been presented. I wanted to thank you both for being speakers on, again, a very, very touchy and difficult topic. We want to thank everyone for watching and for your questions, and we have reached the end of this session. Up next, we have advances in immunotherapy for relapsed and refractory neuroblastoma. And we also, if you have missed any sessions, they will be available on demand right here on the event platform. So the ones from yesterday are available. The organizers too would also like to value your feedback. So if you could please complete the short survey that is available, and look for survey in the side menu. Again, thank you very much for attending and for our speakers and for Donna's assistance. And you can wait here for the next session. Thank you. Thank you.